I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. We're going to focus on digestive health today, and I'm joined by one of my friends and colleagues, and actually one of the doctors that physically works in my office, which I have so much gratitude for, Dr. Dominique Vanier. Thanks for joining us on the show today, Dominique.
Thank you, Jordan, for having me. I'm excited that this is my second time here.
This is your second time, and actually, the last podcast we did together, which was on bloating, still rings in as the most downloaded episode we have ever done on Women's Health Unplugged. Yeah, so if you haven't listened to that one's worth going back and listening to. It's still the number one episode after a couple of years. But today we're going to shift gears and talk about a couple of different digestive symptoms, and one that I think most people can resonate with at some point in their life. We're going to talk about heartburn and help you get some insight around like what terminology we actually should be using to describe this. I'm using the word heartburn, but we're going to capture actually quite a few things in that heading and talk about some of the myths around this, how maybe some of our prescribing practices have changed. And I can't think of anyone better to have this conversation with us than Dominique. Dominique, can you give us a little bit of an intro and a background for how you became a digestive health focused naturopathic doctor?
Yes, absolutely. So I actually switched my careers in my late 20s to become a naturopathic doctor. And it had a lot to do with my personal health history of having a long-standing chronic digestive condition. So I was diagnosed with irritable bowel syndrome, IBS, when I was in my early 20s. And so that was, the main impetus of me wanting to really support other people with digestive conditions. And then particularly with GERD. So I do have primary relatives that have GERD. So first is my younger brother, and he has a long history of GERD, which is gastroesophageal reflux disease. And then more recently, my daughter, who's about to turn 1. So when she was 3 weeks old is when she started experiencing projectile vomiting, coughing, what they thought was colic because she just wasn't sleeping because she was in so much discomfort, grunting, and was later diagnosed with infant reflux. And so certainly I have a significant interest in all things gut related. And so that's what's brought me here today.
And you've done some, education for your peers about this particular topic recently. And I think it's important because it's highlighting, not just so if you're a listener and you're like, I actually don't really know anything about this, right? It's not uncommon for practitioners to actually not know a lot about this too. Can you just tell us a little bit about that experience of teaching your peers and what you focused on for teaching the 700 doctors at the Confident Clinician? Like, what did you have to focus on for that session to make sure that they were brought up to speed?
Yes. Yeah, that's a good question. So yes, back in December, we presented to, around 700 clinicians, and it was on GERD, reflux, heartburn, regurgitation, myself and 3 other of my colleagues. And we really focused on what are the myths, what are the foods that are going to trigger it? What are the phenotypes of the condition? Why do some people respond to the main class of medication, proton pump inhibitors, and other people actually don't? What does it look like when somebody actually has been misdiagnosed? What does it look like when somebody even has silent reflux, right? Like the spread of this condition can overlap or can be spread out by many different symptoms. And for that reason, it's heterogeneous, meaning that some person may not look like the other person, even though they both have reflux. And so it was a very interesting presentation where we touched on all those points, from assessment to treatment to, how do we support somebody even when they're not taking medication?
Yeah, because I think, and you're going to explain this to us a little bit. Our perception of this and our understanding of this has certainly got better, like medically, over the last few years, and that should trickle down into change in the way that people are treated. Although we know that that doesn't always happen, and when we make a big change in medicine, sometimes it can take decades before that reaches every individual medical doctor's office. But I think for anyone who's been diagnosed with reflux, their experience has kind of, I'm going to summarize, has been like where maybe they've been told there's some foods that are off limits, or they've had to like deeply experiment themselves to figure out what to do. They also have been told they need to just take medication for life. And then sometimes patients get told about some of the risks of like untreated reflux. We tend to worry about what happens if our esophagus is exposed to acid for long periods of time. And so patients would come in with like a really limited diet, a medication they wish they weren't taking, and fear. And like that was how we treated reflux. So can you walk us through, let's maybe we start from the very beginning around like, how should someone be assessed at this point, and how does someone start to question whether or not they even have acid reflux?
Yeah. So the diagnosis is primarily made just based on symptoms, right? And so typically that person is offered medication at that point, which should actually only be 8 weeks and then reassess after, which is usually like the proton pump inhibitor, such as pantoprazole. There's several others. Sometimes people are offered an endoscopy, which is the scope that goes down the throat and inspects the stomach and the first part of the small intestine. Not every patient who has the diagnosis of GERD or reflux has had that endoscopy. And actually that can make it a little bit tricky because, like I mentioned earlier, there's actually different types of GERD. Like some people don't even have an issue with acid where they don't have excess amounts of acid, or where the frequency of acid events is actually normal, and yet they have these symptoms. And so like going through the right or the proper diagnostic procedure is pretty important to kind of break down, is this an issue with acid? Is this an issue where acid is causing erosion or inflammation, which is like a bit of a red flag, right? Because that needs to be looked at and supported differently than somebody that doesn't have an issue with acid. Is this an issue with how the brain is communicating to the stomach, where somebody who has normal acid but actually feels like they have more, or like the shifts in acid just cause the brain to perceive it in a more extreme way than somebody else. So the condition itself can be a little bit confusing, and certainly like having the right support on how things are diagnosed and treated is really important.
Yeah, I love that the conversation in digestive health is changing, to talk a little bit more about that like gut brain interaction. And I think my hope there is that as patients get better educated about this, that they don't feel like when we're saying that we're saying that it's all in their head. We're going to explain what that means in 1 second. But it also can ease a lot of fear for people, because I think when we have digestive symptoms and we can't see it, we don't really know what's going on in there, it can make us quite fearful that there's this like damage and destruction and like things are being scorched in there. And yet, if it's about that connection with your brain, like physiologically, there might not be any damage happening, and yet you feel terrible. Like, can you just describe what that gut brain interaction actually means?
Absolutely. Yeah. Yeah. And I want to start too with that point with saying that there's about 40 reflux events that happen daily that are normal that we don't feel. Now, some people, where they have like something called visceral hypersensitivity, where their brain just senses their organs at a more like a heightened way than somebody else, is that they can feel those reflux events, and it can feel very scary and abnormal, when actually it's just the way the wiring is along the gut brain axis. And so we call that like an issue of perception rather than a structural issue, where they're just perceiving these reflux events, such as feeling heartburn or feeling like acid come up into their throat, when actually there isn't a structural issue that's causing it. It's just the way the brain perceives it to be happening.
I find that so cool. And it's starting to change the way we're thinking about just gut health in general. But how, like, do we know why someone gets more sensitive? I'm going to say in air quotes, like, why would someone's body be more sensitive to the same thing than others?
Yeah. There's a number of reasons, right? Like it could be, the research suggests, right, that there's like a GI tract motility issue, immune system. It's like a sensitization where the brain is just sensing possibly pain or discomfort greater than it should otherwise. I liken this to irritable bowel syndrome, which is also kind of under the same umbrella of disorders of gut-brain interaction, where we just feel our intestines and the shifts in gas more than the general population. And so there are several causes, and it's still an area that we don't totally understand, although it is nice to see that, at least in the American guidelines 2 years ago when they are updated, it is starting to recognize that reflux hypersensitivity and functional heartburn are actually things where physicians, when they're making the assessment and treatment, need to be looking at how the brain is communicating to the gut and whether that's actually the cause of all the symptoms that the patient has.
Yeah, because you could see how that could go bad both ways, right? Like either if there's nothing there, again, air quotes, we didn't find anything, but someone's like in a lot of distress and in a lot of pain, that can make them feel pretty like unvalidated, right, in their experience. But also when there's nothing there and we don't have a good explanation for it, and then we offer them like a medication, that also doesn't feel very good, because for patients, they want to know if they're taking a treatment, especially one that maybe doesn't meet their values, that we're treating something, right? But this like disconnect in us even understanding that gut-brain interaction can make patients feel like they're being misheard and then mistreated, when neither of those things may be true. It's just that because we haven't had this conversation in a really deep way before with clinicians, that it can leave patients feeling like just unsatisfied with that whole experience.
Absolutely. Yeah. Yeah. Kind of like take the medication and, hopefully come back in 8 weeks, but sometimes not, right? Like sometimes we see patients having taken these medications for decades. And I think it's really important to have the conversation too about like what are the long-term consequences of being on a proton pump inhibitor? Because there are some. And certainly if somebody has been on the medication for more than 6 months, as some of the guidelines are now saying that you want to consider coming off of a proton pump inhibitor once a year. Unless somebody has like significant damage to their to the esophagus, which you would see on the scope, like I mentioned earlier, the endoscopy. But yes, like having the conversation about like what are some of the other options available to somebody, right? Especially if it is a disorder of gut-brain interaction. And something that may tip you off to this being a disorder of gut-brain interaction is when somebody doesn't respond to the highest dose of a proton pump inhibitor, where they still have persistent or refractory symptoms, is we have to look at like, is this a wiring connection issue of how the brain is speaking to the gut? And then, at that point, we want to look at, okay, how do we support the nervous system, right? Like if it truly is kind of like a central nervous system processing or signal issue, is like, we want to look at things like diaphragmatic breathing and gut-directed hypnotherapy and things that are just going to take the nervous system like down a notch or strengthen how the brain is communicating to the gut. And there actually is research on some of those areas, meditation as well, for disorders of gut-brain interaction. Like that is as important of a piece of somebody's treatment plan as is the food choices that they make.
Which I love. So if I was just going to summarize what we just talked about there, it's like essentially if you go into the doctor with symptoms and it feels like that like quick diagnosis, like it's just reflux, just do this, we're probably not like subclassifying that person's experience in a way that's going to give them the best outcome. Is that fair to say?
Yeah, absolutely. Yeah.
And then if things do happen to work and you take that PPI and 8 weeks later you can come off it and you are good, you were fitting into that category that was gonna do that, right? You were gonna respond that way. But if you didn't, it probably means we didn't label you correctly from the beginning. And now we need to start to explore maybe some other ideas.
Absolutely, right. And yes, it could be like like a disordered gut-brain interaction, but certainly we want to be looking at like, did we just misdiagnose somebody completely to begin with, right? That class of medication is very effective at healing what we call erosive esophagitis. Most people do respond well to it. And so if somebody is not, that is a bit of a red flag of like, did something get missed? Right. And certainly the person is still in a lot of discomfort at that point too.
So let's talk a little bit just about the food first, before we go into other lifestyle things. And whenever I think about food and reflux, I always remember this commercial, which you might not be old enough to remember this commercial, but I am. And it was like this guy is in his apartment and the doorbell rings and he's got heartburn and he's like, I don't know, you can tell he's got discomfort and he opens the door and it's all of his favorite delivery people. So it's like the chicken wing guy and the burrito guy and the pizza guy, and on top of the pizza box is a medication for heartburn. And the guy like jumps for joy. He high fives everybody in the hall, right? And he's like, oh my gosh, I can now watch my football game because I can eat my favorite foods and not have discomfort. Every time I think about heartburn, I think about that commercial and that how medication can sometimes mask maybe some of the food choices that people make.
Yep.
But clinically, my experience with it is that like people have reflux wouldn't touch that stuff with a 10-foot pole anyways. And instead they've actually narrowed their diet down to like, wait a minute, did that tuna like look at a tomato? Because if it did, I can't eat it. And
Yeah.
like that's what they're doing versus the like, high-fiving the chicken wing guy. But can you just give us some insight on around what's true about the foods with respect to heartburn and GERD?
Yeah, absolutely. And that sounds like a great commercial. And I don't think
He was like
I don't think I've seen
high-fiving
it.
down the hall, and it was like, and
All
I
the
remember
delicious foods, right?
I might have been in naturopathic college actually, where we had a TV that we did not have cable because we could not afford cable, and you had to like tilt it a certain way, and we could only get CBC in my apartment. And yeah, I like distinctly remember being like, I feel like he shouldn't be eating those foods if he feels that badly.
Mhm, mhm. Yeah. But yes, to your point, it's not uncommon to see people cut out foods, right? With the attempt of I just want to feel better. And I call it like going down this rabbit hole after rabbit hole. Like it's just this one, I gotta find that one food that's bothering me. And I'm gonna cut it out. And I haven't found it yet. So I'm gonna cut out another food, another food, another food. And I like to say, like, well, you're basically eating cardboard because you've cut out like your gluten, your dairy, your soy, your all your grains, like certain vegetables, and it's such a restricted diet at that point. And when we know like long-term diet restriction is going to shrink our microbiome, we know that there is an impact on the species, the diversity in the gut. But the second piece, equally important, is that it can change our relationship with food. And so we see this across the board with pretty much all disorders of gut-brain interaction. When somebody has cut down the foods that they eat, is it can lead to this fear-based mentality, which in itself is like revs up our nervous system. If we are fearful of the food that we are putting in our mouth, how are we going to digest that if we're kind of in this like fight or flight nervousness when we're eating? And so that's where it's really important to, if we are, if we're evaluating whether a food is causing somebody's symptoms to be aggravated, we need to do that in a very calculated, methodical way where there is absolutely a reason and a need to temporarily take out a food from somebody's diet with a reintroduction plan as well to confirm whether that caused the issue to begin with. I will say, though, for quite a few people that fit under the umbrella of disorders of gut brain interaction, they will say they have, let's say like, I don't know, yogurt one day, I'm just picking any food, and they're okay eating it. And the next day, same quantity, same food, and they're aggravated by it. So how does that make sense, right? Where like one day they're okay eating that food and the next day they're not? Like, are they truly sensitive to it? Are there other factors at play? Was it their environment? Was it because they like were like eating in front of their computer and had like urgent emails coming through, and you know what I mean? So the choice in removing foods does actually go more broadly than the food itself. And there are other factors that need to be considered there. That being said, there are some known aggravators for reflux, although actually the research was more mixed than I had anticipated it to be. But things like, foods high in fat. So going back to that commercial you just mentioned, like there was probably some high saturated fat in a lot of those foods. Things like carbonated beverages, chocolate, sometimes coffee, but it depends on how much. Sometimes alcohol, depends on how much. And it also kind of depends on the person. Like even just talking individually to people is some people have no problems with 1 or 2 glasses of alcohol, and some half a glass is going to set them off, right? So I do question whether even the research reflects those 4 different types or 4 different phenotypes of GERD or reflux when they are doing those studies.
Yeah, that's such a limitation we have. Like when there's so much individual variation on things, like, because food isn't just food, it's timing, it's stress. Like well, it shouldn't be stress, but I mean, you could eat food like in a situation of stress. And so even if we gave 100 people like a meatball sub, like if you're eating it on a park bench, or you're eating it at your computer, or as you drive frantically to go pick up your kids, because how does school end at 2:10? Like, I don't understand how parents do this. Like that's a very different situation, same food, right? And in research, what do? We say, well, how was that meatball sub? Right? Like we don't look at like, well, why did we pick a meatball sub in the first place? Because we have no time. We also have maybe that group of individuals they studied maybe don't have money to purchase like other foods. So researching food is difficult. And I think in the past, it's led medicine to kind of blanket statement and be like, food doesn't do anything because we didn't have the capacity in research to like get into the nuance of each individual person's choice and study it. And it's even still we struggle with that. Whereas as practitioners, when you work with people one-on-one, it's that one time where you say, well, the research says this, but if your half a glass of wine is bothering you, like, I don't know, maybe we stop that.
Right. Maybe that's not a good idea.
Maybe not, but it can leave people feeling so confused because they can easily go online and see someone like poo-pooing individual diet change for digestion because the research doesn't back it up, which is true. But then when we actually ask them about the foods that were helping them or hurting them, or even their process for getting diagnosed, there's so much room for supporting them. It's hard, right? Like it's hard to do that research to practice thing. What do you notice in your practice? Like how do you navigate that?
Yeah, I do find the exercise of tracking the diet, and we're not talking about long-term tracking, right? Because a lot of the time patients will come to me and their diet, like there is a high level of control over their diet already, and probably like a lot of similarity the day to day. So a week to 2 weeks maximum of tracking the diet of how, what are some of the patterns we notice, right? Like, how much of that food did you eat? When did you eat it? Was it before bed, right? Like, did we have an overnight fast? Did that help your morning symptoms? And then tracking and relating that to what they were feeling, right? Like, what was the level of pain that they were in? Like, did you feel acid come up into your throat? Did you have extra symptoms like clearing your throat or coughing, right? Which can actually all be part of reflux as well. And then discussing like the things that we know are more likely to support somebody, such as like the physical support wedge pillow, avoiding eating too close to bedtime. There's several other things that can support somebody, but I do find, like I said, the tracking exercise can be very helpful both for me and the person, because when they're doing it, they can identify some patterns or little just windows of information that maybe they didn't realize before.
Hmm. Yeah, it's so easy, especially if we have a medication that will maybe blunt some of those experiences or whatnot to like lose lose track, or we're not as connected maybe to those symptoms and the way that we feel. Um, and asking patients like, well, what did you notice when you had to do this? And they're like, I noticed that I seem to eat out my lunch like 3 days a week, which I didn't even really realize it until I had to put it on paper. So I do think that's such a valuable exercise.
Mhm.
Let's talk about the medication for a second, though, because the prescribing has changed on paper. I don't know if we're seeing it quite yet in practice, but we definitely used to imagine those proton pump inhibitors or acid reflux medications as being like a lifelong prescription. And by the sounds of it, well, I know because you've told me, even though this is not my area of expertise, that the guidelines have actually changed on that. So what does that look like now? And then how does someone who's listening to this, who's like, oh, I've been on my, PPI or my Nexium for 10 years. Like now what do I do?
Yeah. Yeah, I will say, like, in a lot more recent conversations with patients, it's nice to hear that, when their family doctor or even gastroenterologist has prescribed that PPI, it's 8 weeks and let's reevaluate after, rather than like, see you later kind of thing. Um, what's a little bit annoying is that the Canadian guidelines are super outdated, right? Like they're actually 20 years old. The American ones were more recently updated rather. And so there isn't like a universal agreement on when somebody should discontinue or be deprescribed their PPI. It is somewhere between 8 weeks to 6 months is generally what the resources are recommending. But I think, in having the conversation with patients when they are initially prescribed a PPI is like that time frame should be discussed with them, right? Of like, this works really well. We're going to consider you stopping it at 8 weeks. If you still have symptoms, this is what we're going to do. There's also quite a few patients that like had this conversation with their doctor when they were prescribed it, let's say 5 years ago, and like we're never told when to actually stop it, and they're just still on it. And, the conversation about like, what are some of the long-term, side effects of being on a PPI? Well, we know like it can increase somebody's risk of having an E. coli infection, of C. difficile rather, and then reinfection of C. difficile. Like we know it may affect their magnesium status or their B12 status. We know it may increase the risk of fractures, right? And all those things are really important. So like if there are other options available to somebody, especially if they don't have like severe GERD, then somebody I think needs to be empowered to know that those are available.
Yeah, I can't believe that those guidelines haven't been updated in 20 years. That sounds like a sweeping like generalization. Like, it's been 150 years since we've like, right? Like almost like an exaggeration, but it's actually 20 years. Like there is nothing in medicine that we haven't learned something in the last 3 months, let alone in the last 3 years or 20 years. I know that it takes a long time for standard of care guidelines to change, but that amount of time, like there's new classifications of GERD that obviously are not even reflected in the rules on how you treat GERD. And yet we opened this episode with like, yeah, there's some of you that are just going to respond beautifully, but if you didn't, it's because we're talking about something else. How can that even be reflected in the guidelines if they haven't been updated in 20 years?
Exactly. Yeah. Yeah. It certainly is an issue, right? To the point where like even the instructions on discontinuing somebody's PPI before they go for that endoscopy is not referenced in the Canadian guidelines. It is in the US guidelines, but when we're doing a scope to like evaluate the extent of tissue damage that somebody has because of the issue with their acid, we don't want them to be on the most effective medication, because then it actually blunts the ability to evaluate the extent of tissue damage if they're taking that medication like the day before their scope. And so, yeah, it would be nice for the guidelines to be
All we're asking for is just
updated.
update the guidelines, please.
Exactly.
Whoever's listening in power. Well, and it's funny because that, and I've worked with patients where I wanted them to get tested for, say, like H. pylori, and the recommendations around that, you have to discontinue your PPI. But when patients have never been talked to about coming off that medication, their fear about coming off the medication is so deep, right? That they would almost rather not have some of those diagnostic procedures because they don't want to miss a day of their PPI. And even that alone makes me feel like, well, we're obviously not hitting the nail on the head if now one day without this medication is like life altering. But it's partly because of the language we use to talk about that prescription that's put that fear into people that like they will never come off it. You can't come off it. Don't miss a day. And now here we are asking them to come off of it to go get a scope done. Like that won't compute. But if they had known from the beginning it's supposed to be temporary, that can empower patients to change or to
Absolutely.
be like connected to a process rather than this is just how it is now.
Yeah, for sure. Right. Like there are so many modifiable behaviors from dietary choices to like, your choice of pillow to even like evidence-based effective supplements that have good research behind them for supporting like the lower esophageal sphincter, for supporting motility, and as well as like the gut brain activities that I mentioned earlier. Like there really is kind of a full encompassing whole body approach of a treatment plan that somebody could have that can set them up for success of not experiencing reflux anymore, or to a significantly lesser extent.
Yeah, like you think about like what would that feel like, right? If you've spent your whole life on a medication that without guidance or like without feeling like you're on a path, right? You're not on a journey if you're just supposed to take it every day, but also probably some dietary restriction that goes along with that, and never really getting to the bottom of it. I think most women who are listening to this podcast have this deep desire to get to the bottom of their health, right? Like they want to know, like, well, what can I do? Right. Like so much so that they're even listening to a health podcast because they want to know what they can do. And this is one of those conditions that we've never really made people feel like there was anything they could do. And yet, like, that's not actually the answer. The answer is you can do a lot. You can change your path, right? We can help support you, but you probably can't do it alone. And you probably don't know where to start if you have either been told to just live with it and you're unmedicated, or you are medicated and yet now you 8 years in taking medication after your pregnancy for heartburn and no one's helped guide you for what to do next. Um, how do our listeners get in touch with you, Dominique? And what does that look like to work with you?
Yeah. So I'm located in Burlington, Ontario at at your clinic, Clarity Health Burlington. People can get in touch with me on my website, drvaniernd.com. I'm on Instagram and Facebook as well, regularly posting about all things gut health. And working with me one-on-one generally involves, a few appointments to start off with, but like I like to talk about like what proper assessment, proper treatment, right? Like a lot of people come in here where it's like a lot of band-aid solutions of, taking the supplement or taking that supplement or taking my medication, occasionally, right? Like we want to know what's going on. Do you have your endoscopy report? Like what does it say, right? Like was it a normal scope, or like did we see significant like erosion or inflammation there, right? Like feeling empowered is one of my main goals, where patients can feel educated, that they have a lot of control in the choices that they can make, as well as discussing like what's the top research for supporting gut conditions, and what does that look like in somebody's life where hopefully there is increased freedom with food choices, as well as a resolution or a significant reduction of the symptoms that they're having from day to day that have been affecting their quality of life for a long time.
Yeah, I love, like, it's one of the things I've always loved about naturopathic medicine is that, we can get, as things evolve in medicine, we can pivot with it so much faster than conventional medicine. And sometimes that can be to our detriment, right? Like, you can certainly see in the health and wellness space that we're pivoting too fast or we're pivoting on research that maybe is not that solid. But for you and I and for evidence-based clinicians that practice naturopathic medicine, we actually have this ability to take research and implement it into patients' lives when the guidelines have not been updated for 20 years, right? Like you deserve better than that, really. Let's be honest. You deserve your gut symptoms to have research that was published like in the 2000s, first of all, right? Like those guidelines probably, I'm really harping on this. These guidelines probably took 3 years to write. And so 20 years old from the date of publication, but when was the actual research done, right? So you deserve better than this. One of the things I've always loved about what we get to do with patients is that when something really revolutionary comes out about the way we think about a condition, the way we think about food, the way we think about treatment, we actually just get to do it, right? With patients like right away. And so if you've waited 6 months to have a specialist appointment and we're really underwhelmed by the experience, they're reading from a playbook that was written like, a long time ago.
Yeah, absolutely. And certainly, like, you can see your other practitioners, including naturopathic doctors, while you're waiting for that specialist. Like, there are so many things that somebody can do to improve all the other factors that are directly or indirectly related to their reflux in the meantime. And they may be pleasantly surprised that, like, that appointment, when they're waiting, like, by the time they have that appointment, is things have much improved.
Well, I really appreciate this conversation, Dominique. So thank you for spending time with us today. And we're going to put the link to Dominique's website and her Instagram and all of those pieces in the show notes. And so if you're tired of being a fire-breathing dragon, which is how I always described having reflux in my pregnancies, now you know where to turn. No. Thanks so much, Dominique.
Thanks for having me.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.